Cry It Out Loud, a podcast by Chasing the Rainbows with your host, Bernice Quisenberry.
Welcome back to Cry It Out Loud, the podcast where we break the silence and talk openly and honestly and unapologetically about infertility, baby loss, pregnancy after loss, and everything in between. I'm Bernice, CEO of Chasing the Rainbows and the host of Cry It Out Loud podcast. And today we have a very special episode for you. We're launching our quarterly Ask a Maternal Fetal Medicine Doctor segment with one of the foremost experts in the field, Dr. Serena Wu, a trusted and respected maternal fetal medicine specialist and fellow baby loss survivor. Serena, it's truly an honor to have you here with us today.
Thank you for having me, Bernice. It's wonderful and an honor to be asked to speak today on your podcast.
Great. Well, thank you so much for joining us, Serena. Our listeners always rave about the depth and clarity you bring to these conversations. Today, we're diving into some incredibly important questions from our audience, many from survivors who are navigating pregnancy after loss. These are the kind of conversations that truly matter, and we're just so grateful to have you here to guide us. And before we begin, at Cry It Out Loud, we want to emphasize that while we strive to provide valuable information and support those that are, looking for some answers through our maternal fetal medicine doctor segment, the content shared in this podcast is for general informational purposes only. It is not intended as medical advice, nor should it be used to diagnose or treat any medical conditions. Every pregnancy is unique, and the information provided should not replace personalized care from your own healthcare provider. We strongly encourage you to consult your doctor or a qualified healthcare professional for advice that is specifically tailored to your solution. Your health and well-being deserve nothing less. Thank you for being here with us, and we hope this episode sparks meaningful conversations that support and empower you on your journey. So now let's dive in. Serena, one of the first questions we received is about the timing of delivery for someone who is pregnant after loss. So a listener is wondering about the pros and cons of delivering at 37 weeks versus waiting until 38 or 39 weeks, especially when considering any potential complications from both mom and baby. So, for example, when our anxiety is heightened with our pregnancy after loss and the doctor suggests delivering early at 37 weeks, what does that look like in your professional opinion?
That's a great question. And actually, it's usually the other way around, where doctors will probably not necessarily talk to you about an earlier delivery, since it is not ACOG, that's the American College of OBGYNs, recommended. It is still recommended that we deliver at 39 plus weeks. When most women actually ask if they can deliver sooner, especially depending on the timing of their stillbirth. I mean, if you had a stillbirth at 38 weeks, nobody wants to get to 38 and then keep going, given what had happened previously. So most women ask if they can be delivered sooner, and that usually needs a conversation with your OBGYN or MFM provider, whichever one that one ends up seeing throughout their pregnancy. And usually it's not one or the other. I mean, it just depends on where you go for your prenatal visits, how they employ their maternal fetal medicine specialists, or if you mainly are just dealing with the OBGYN. And for some women, it's a choice. Sometimes they do want to stay with their midwives, but the midwives need input from either an OBGYN or the MFM. But what it comes down to is that it's an individualized approach. And while it's not a recommendation that you deliver sooner than 39 weeks, it certainly is shared decision making, and that we would work with you and with your OBGYN provider to discuss the timing that might work best for you and your family. And that could be 37 weeks. And 37 weeks is considered term. It's early term. And it's where we wouldn't recommend delivery sooner unless there was another indication for that.
Okay.
So, and what that would look like would be more of a discussion about, not only the induction process, but also that while your baby might be considered term, there still might be some issues that need to be dealt with, and that might need to be dealt with by the NICU or the neonatal intensive care unit. Most babies are ready to be out by then, but there's no obvious guarantee, and there may be some transitional issues. So that is organizational or location specific, and that would be where the discussion with your OBGYN or MFM provider, what is your experience here for a 37-week delivery? Is it less than 1%, which I would probably guess it would be, but like how often does a baby need to go to the NICU for transitional purposes? I had a patient who had a term demise, and we recommended a 37-week delivery. She needed a 37-week delivery.
Yeah.
I would not have expected it, and certainly neither did she, but the baby needed 8 days in the NICU, despite being 37 weeks. So even, and that's extreme, I have to tell you. That's not what I certainly anticipated at all for a 37-week neonate or fetus eventually delivered. So you just never know. Every baby's different. Every baby has their own individualized needs, and some, even though being 37 weeks, might not be ready in their own way of being outside. And that being said, people think that 37, 38, 39 weeks, why not just deliver? And the reason is that the brain is still growing, the lungs are still growing. I mean, yes, everything's formed, but there is something that mothers do still do give in that last month, that there is the most growth for baby, for the organs that are necessary. So if we don't have to recommend delivery early, we certainly don't want to. But at the same time, our organizations do recognize that anxiety, that trauma, and that it comes down to just having that personal discussion with your OB provider, with your MFM specialist, and even with your NICU to find out specifically what happens in your own hospital, like what are the outcomes. That being said, so usually most people don't want to go later, but there are those questions that, well, what about, can I go past 40 weeks? And I would say that's usually not the most common question, but sometimes you get that, and we definitely do not recommend going past 40. And actually, I think across the nation, there is a push for even low risk women to have babies by 40 weeks, not to really necessarily go past 40 anymore.
That's great. That is wonderful to hear, Serena, just from, hearing survivors and, getting them in at 41 or 42 weeks and, having a stillbirth and things like that. So, right. Thank you for sharing that. I didn't realize.
Yeah, it's not common, I have to tell you, but there are, I think there are questions in that vein, because the process of delivery and the process of feeling like, this is a natural birth, that like the process is very important. And while trying to honor someone's process and what they want from the pregnancy, we also need to balance. We'd like to balance a recommendation and how to best honor both.
Yeah, absolutely. Oh, well, that's really helpful. Thank you, Serena. And it's such an important topic. And I know many of our listeners will feel reassured about this advice. And, it sparks at least conversations with their MFM or OBGYN when they go in, or whoever their PCP or healthcare provider is. So
Yeah.
thank you. Yeah.
And,
Now,
and
yeah.
I guess just for the listeners too, I mean, there is no hard, fast rule. If your provider says, okay, let's talk about a 37-week delivery, and for the person who asked that question, well, you like, maybe they didn't want a 37-week delivery. Maybe they really just didn't want to go to 39, but was wondering about maybe 38. There is no, just to put it out there, there's no hard, fast rule that it has to be 37 or it has to be 38 or, it's if your provider is telling you, well, this is what we are recommending, then open up that discussion, because there's nothing that says you absolutely have to deliver at this time just because of, and then having that plan, being able to be flexible as well.
Yeah. And I think recognizing that, because the birth plans definitely, I mean, each time, all four of ours, our birth plans pretty much went out the window. So yeah, I think having that flexibility is key, right, Serena?
Yeah.
Great. Now, the next question comes from a listener who's pregnant and has been prescribed Lexapro to help with anxiety during her pregnancy, with plans to switch to Zoloft afterwards because of breastfeeding is the plan. And she's understandably concerned about taking medication while pregnant because of, being pregnant after loss, and wants to know how anxiety medications like Lexapro and Zoloft can affect the pregnancy and the baby. And she also asks about the FDA's like drug classifications, like class A, B, and so on, like what those different levels are, like grades pretty much. Can you explain these classifications and how they relate to the safety of medications during pregnancy?
Actually, so that's a great question. And actually those FDA classifications, A, B, C, D, X, the FDA got rid of them. I mean, so 2014, the FDA changed it.
Okay.
We no longer have them, even though you might still see them.
Yes. And that's how they're referenced still. At least they were when I was pregnant, right?
And the FDA got rid of them only because it was pretty much too simplistic, and it's still being misinterpreted or still misunderstood. And right now what's in place is it's still kind of vague, actually, but it's supposed to provide more information for patients and for the providers who prescribe those medications, at least to be able to talk a little bit more cogently about the risks to the pregnancy during pregnancy and during breastfeeding, during lactation. And they've certainly expanded the category a little bit to talk about the risks during pregnancy, risks during lactation, and then specific risks to males and females. So the categories actually are no longer there. If your provider references any medication A, B, C, D, I mean, that's just antiquated now. But in all intents and purposes, if your medication or prescription was an A, that's basically, your prenatal vitamin that has been proven to show no harm whatsoever. And I can tell you, most medications never fell in A. They always were B or C. And that's true of all medications. I mean, so X is the one that you would, your physician or provider should know about. That's the one that's just completely contraindicated in pregnancy. So it's no longer called X. We would just be, no, you can't take that. Moving on to, Lexapro and Zoloft, they're SSRIs. And really, after the first trimester of pregnancy, you should be able to take any medication that has been prescribed, because knowingly, I would say your provider would knowingly not prescribe a medication that would be harmful. I think it's interesting. The common question we get, well, is that harmful to our baby, or is that harmful in general? I think it's an interesting question, because I don't think any provider would knowingly prescribe any medication that would harm you, or you or the baby during pregnancy. After the first trimester, so I think what we think about is that I think people think about, can this medication cause a birth defect? Well, after you get out of the first trimester, you're not going to create a birth defect. So everything is forming in that first trimester. The heart forms like basically in the week 6 to 7. All your fingers and toes, brain, everything is done by the 12th to 13th week. And you're now, once it's done, it's done. So you're now not going to, at 20 weeks, create a birth defect just because, by starting a medication or taking a medication. So a lot of people try to stop what they're taking for that first trimester and then restart it after that. And so I reassure people, I do a lot of reassurance that if you need your medications now, because a lot of people stop cold turkey.
Yeah.
If you need it, please start it, because actually your mental health and why you need those medications is more harmful to you, because we do not know the effects of your own, of what is going on in your own body, and those either those hormonal levels or their neuronal levels. We don't know what's going on that can affect the balance of what is going on in the uterus in the baby. So, we have I think the tricky part is that people think that, I believe, and I might be wrong, that the reason why people stop their medications is because harm to baby and a birth defect.
It's that worry. It's that guilt. It's that shame, blame, Serena, because you don't want to do anything, just speaking from experience with myself, I don't want to do anything that's going to harm this pregnancy because of what happened in the last one, and having to deliver early and all the things. Is there something I could have prevented, or what, and going into a pregnancy, maybe not on a medication before and then being on one because of the loss, right? And then going into pregnancy on it, and then you're nervous, is this going to do anything? And even though they're saying there's a potential for this, but it's more important, it's just really trying to navigate and weigh pros and cons, like you're saying, especially with those elevated hormones and things like that. So I mean, so and then SSRIs, I mean, there is this risk if you're on an SSRI like Zoloft or Paxil or Prozac of maybe a withdrawal syndrome at the end. So after the baby's delivered, or concern for a cardiac defect. But these are, that was one study. Actually, we do not even do a targeted ultrasound of the baby's heart just because you're on these medications anymore. We used to. There is, again, like I said, one study that showed maybe an association, but all the other studies do not. And then, I spoke with a neonatologist that basically is like, yeah, we don't see the withdrawal syndrome. So if the mom really needs to be on the medication, I would advocate to be on the medication. Just to help for mental health, just wellness. And, we need to be well to take care of others, right? So absolutely.
If you're not feeling your best, or you're not where you should be, then how can you take care of somebody else?
Absolutely. And I think too, if there's anything you can do, to almost enjoy the pregnancy, because I know I did not, I didn't choose medications while I was pregnant or anything. So it was a really big struggle mentally, to be honest. And I was in the hospital a lot because of fear and anxiety. And that probably could have been controlled better through prescriptions. And I probably was like the ideal candidate for it. And it made it very miserable as a pregnancy, to be honest. Like I regret it now and, have a little guilt with it because I didn't really feel that connection or sense of enjoyment with our 2 pregnancies after loss.
Yeah, it would be hard. I mean, it's hard to be connected to something that you feel like you might lose.
Yes.
So,
Yes. We've already
yeah.
lived it. Right. Right,
Yeah.
Serena. Thank you. Yeah. And that's, this is all incredibly important, especially, when you do feel nervous about taking any medications or, even addressing this with your doctor, talking about it. It's just great to know, you can feel comfortable. You can go your explanation, and talking through all of the, different concerns that you could have. So thanks, Serena. We also, received some questions from listeners dealing with conditions. And this was a big one for me as well with my pregnancies after loss was like endometriosis and PCOS, things like that. Like curious how these conditions can affect pregnancy, if there's any specific procedures, supplements, or medications that can help manage cycles or improve chances of a healthy pregnancy, leading up to and all of those things. If you could just like kind of touch on that a little bit more. For our listeners.
Yeah, it's certainly, I think PCOS and endometriosis, I think hits more the infertility aspect. And certainly you may or may not see an MFM for that, more likely not. It would be something that maybe if you had recurrent miscarriages, that you would come and see an MFM, but that would still hit more infertility. But that being said, I mean, PCOS, certainly there are irregular cycles with that. Endometriosis, I know there can be irregular cycles, and it's a whole journey. That's a whole separate journey for sure.
100%.
Trying to figure out why and how, and then what can we do about it.
Absolutely. Yeah.
I know for yeah. Oh, I'm sure.
It's episodes with fertility docs for, survivors out there who are looking for, or seeking information or seeing, if their cycles are irregular, to feel free to hear about. But yes, Serena, it's interesting because, I didn't think about like, how would this actually affect a pregnancy before until we went through everything with Brooke and realizing that there might've been a factor with a fibroid or a system, I apologize, with PCOS and things like, and in the uterus and things like that. And it is so interesting, because you try so hard to get pregnant and things like that when you have these conditions, and then you do get pregnant and then you're like, oh crap, like I didn't think about all the scar tissue and everything else.
Yeah. It depends on everybody's individualized. And so I think, in general, I feel like I'm not doing it justice to just say, just kind of a blanket statement, because endometriosis can be anywhere from, very kind of mild, I guess, to very severe, where it affects the different organs, and you might have extensive surgery. And that obviously, I think your OB provider should know about, but that could have some effect when time of delivery.
Yes.
But either one, both of those conditions do have some impact on the pregnancy once you get pregnant. Certainly both, there's an increased risk for gestational diabetes. I have seen more women with PCOS who there's already an increased, and they know it themselves too. It's interesting. Have an increased insulin resistance. And so they're already maybe on metformin, a drug to help with, that is known to help regulate their cycles, as well as help with lowering their blood sugars. But we know that having elevated blood sugars coming into pregnancy is almost like taking a medication that you shouldn't. High blood sugars actually act as a teratogen. So having that diagnosis of PCOS and figuring out what your blood sugar levels are actually really important, because you don't want to come into pregnancy basically being diabetic, or finding that out for the first time. Then it would be nice to have that already known, and that you are working on taking care of that.
Yeah. Almost like your own baseline, right?
Yeah.
And then understanding, so then you can really regulate and watch and monitor. Yeah. Okay.
But yeah, so, and then most women with endometriosis, again, it depends on
the severity and
and then I think there are a whole host of other anxiety and fears when it's taken X amount of years to get pregnant. I think because most women with endometriosis tend to have normal pregnancies. There might be an increased risk for gestational diabetes or hypertensive disease of pregnancy, miscarriage, but that miscarriage is in the first first trimester, so you're not going to have a miscarriage after that, meaning it's not termed miscarriage at that point.
Yeah, that's good to know, Serena. Yeah. Oh, thank you so much for explaining all of that, because it's such important information for those, just like I said, just to spark the conversation for us around endometriosis, PCOS, things that are almost becoming more discovered, I feel like, instead of just like painful periods and things like that. It's diving more into this and navigating those conditions, and then, pregnancies with it. So before we wrap up, is there anything else you'd like to share with our listeners, especially those who are struggling with pregnancy after loss?
I think what's really important is that if you have a support system, that next pregnancy is always, I feel is always, maybe not, but it is very anxiety provoking, and is something that I think having a strong support network, whether that's other baby loss survivors or your therapist, I would having that support around you to get you through day by day or week to week, and especially around the time of the loss, is something I would definitely recommend. As well as, if you can, finding a provider that can help you individualize the care in that next pregnancy. If you have a provider that you feel does not understand, or is not is being more paternalistic and telling you what you need, it might, and you can't seem to open that conversation, I would reach out to other people to see what can you do about that. I'm not advocating for you necessarily to leave that provider, but certainly, finding people who and finding providers who can help you through the next pregnancy.
Right.
Because nothing, yeah, exactly. Because there are certain things that are pretty standard of care, like having your prenatal visits every 4 weeks.
Yes.
In the beginning, and then it becomes 3 weeks, and then it becomes 2 weeks. But that is also individualizable.
Yes.
What was nice when, yes, it was every 4 weeks, but one of the things I did was that because I was a referral service, I could tag team with the primary OB, with my OB colleagues, and so that person could be seen every 2 weeks. So they'd see me only every month, and they see their doctor every month, but it would be every 2 weeks that they get seen by somebody.
Yes. It's nice to stage it out like that, because it's that extra reassurance, only going 2 weeks in between appointments and things like that. And that is really, after, loss and things, great to have.
Yeah. I mean, because it seems, even now, in the practice that I am in now, it seems so strange to me to have that first trimester ultrasound at 8 weeks to confirm that you're pregnant, and then go not be seen by ultrasound, not have your baby looked at by ultrasound until 20.
Yeah.
And that's the way it's been scheduled. It doesn't have to be that way. Obviously, your provider can put in more ultrasounds, but that is the standard at where I'm working now. And it's odd for me since that's not typically how I practice.
Right. And I think that just goes back to the bonding connection is so important. And it's always worth having a conversation because you really are putting your life and your unborn baby's life in the hands of your doctors. And so you need to feel that sense of security, safety, and feel like they're a part of your birth plan and not against your birth plan. And like if you can sit there and you can really feel like they're on your team, that in and of itself is just so important, especially with those pregnancies after loss, because I feel like my eyes were really opened to a lot of different things that I was kind of naive to prior.
Yeah. Yeah.
So,
When you don't need to think about it, it's kind of nice, right?
Yes, right. So it is always worth, like, we definitely interviewed doctors and it was okay. Like we were very, open and honest about it, but I just really wanted to see like, okay, who's going to deliver our baby and just like open those conversations. And we did end up switching and it was just based on our comfortability. And it really does come back to that and your safety and security. Yeah.
Yeah.
So, well, thank you, Serena, for your beautiful words and, for your valuable insight today. And I know our listeners are going to walk away from this episode feeling so much more like informed and supported. And for anyone listening out there who may have questions or, need any of our support services, we have, up to 4 support groups a day. A podcast is an extension of this. We have therapy, peer mentors, yoga, breathwork, meditation, anything that a survivor needs, we will get them connected to. And we will be back next week. Serena will be back for our quarterly episode. So please, pay attention to social media for that. And until then, please take care of yourselves and each other. And thank you for listening to Cry It Out Loud. Thanks again, Serena.
Thank you so much.